Thank you very much, Rox, for these kind words. And I have to move a little closer to the screen here because I had my eye surgery. Anyway, it's always a pleasure and honor to be here and talk about something that from the very beginning on, I was biased. And I remember 2006 when I was with a very close friend in Germany, we did our early TAVRs, and I said, if TAVR is going to be successful and if we move forward with TAVR into younger generations, I think at some point we have to protect the brain. So get back to the lab and see what you can do in order to protect the brain. So the 2006 story turned out to be a real uphill battle. And today we talk about two so-called negative trials, and some of the previous speakers already touched base on that. And I will go a little bit more into details. Financial disclosure as shown on this slide. I can say it hasn't changed much, except I have to add one more, that's Valve Medical. And I also would like to start with a personal disclaimer that I believe that protection of the brain should be standard of care in all patients. So that is something that I have to send to you before I continue. And the arguments that we hear are summarized here. TAVR, or stroke in TAVR, is declining with every generation of TAVR systems. In high volume centers or experienced operators, stroke has almost disappeared. Stroke is more prevalent in high-risk patients, as low-risk patients will have less debris. Cerebral protection is complicated to use and adds risk and time to my procedure. There's really no evidence that it actually reduces stroke with two negative trials. The only available device, Sentinel, doesn't cover all four arteries supplying blood to the brain, and of course it costs too much. So those are the arguments that we hear, and if my talk would be a little bit longer, I would go through each of those, but we don't really need that. This is something that was mentioned before. There is significant concern for TAVR patients in the audience response at the ACC, and look what the response was. What is the biggest concern for your patients undergoing TAVR? 70% answered with suffering stroke, much less than dying. And the other one is cerebral protection necessary during TAVR? In some cases, in selected cases, the majority said yes. I think that's a very interesting poll because it tells you how important protection is. We also know that injury to the brain is a facet of various clinical signs. To the left, very obvious, to the subclinical, with different percentages. But we do know whatever happens to the brain is not immediately seen, but maybe even a long-term consequence. And that's something that's very difficult to prove. And that is obviously later CVA, cognitive impairment, and vascular dementia. Now, all of a sudden, cardiologists turn out to be neurologists, and we know at the very beginning that was wrong. That's why the trial, or the two previous trials, address that issue. Effects of stroke after TAVR is very clear: increases mortality, decreases rate of discharge to home, increases rates of 30-day readmission, and has a higher index of hospitalization cost. I think that's very clear, and we don't need to discuss this. Stroke after TAVR, however, and that is the problem, remains very difficult to predict. We don't know when it happens, and if it happens, it is a disaster. Stroke is a devastating complication and not comparable with other possibly minor complications. And that's also important to remember if we talk about complications after TAVR. So if we look at protection with Sentinel, that was the first device that is approved in the United States. We know in the Sentinel protection, the Sentinel IDE trial, we captured debris in 99% of the patients. So in every TAVR procedure, something comes off and doesn't go to where it belongs. The device was safe. It didn't add any MACE at 30 days. And in a post-hoc analysis, reduced stroke 72 hours post-TAVR, also something that we should note. Single center studies, we don't need to go through the details, but here you see studies from Europe and from the United States were all in favor of using sentinel versus no sentinel. And then came the hiccup. The TVT trial on the left side, and then the German registry with 41,000 patients were not in favor of sentinel or did not see any advantage of protection. And that was when the problem began. So basically, the summary of the TVT registry then was that there was no stroke reduction in the primary analysis, although there was a modest benefit in the secondary analysis. And the findings support its clinical equipoise and provide a strong rationale for ongoing large-scale randomized trials to test whether protection devices provide meaningful clinical benefit for patients undergoing TAVR. That's really very reasonable to do, but it's also very difficult to do a randomized trial. As we know, for example, with bicuspid stenosis, it's an ongoing discussion. Personally, I believe it will never happen, even though maybe some say it should. And here we have the two. You've seen this slide before. Protected TAVR came out. We know the results, and I will talk about this briefly. And then the BHF Protect TAVR with close to 8,000 patients. Basically the same thing in the UK. New England Journal of Medicine published that. The Protected TAVR study was the objective to study whether clinical stroke and transfemoral TAVR is reduced with protection across all risk groups and commercially available devices. The design, prospective, post-market, multi-center randomized controlled trial in 51 centers in North America, Europe, and Australia. You can see one-to-one randomization endpoint, all stroke at 72 hours after discharge. Here's one of the problems already. Statistical method at the time when they conceived this trial, the control was 4%, and there was supposed to be a 50% reduction with sentinel 2%. Then there was an adaptive study design, planned enrollment, 3,000 patients, and the DSMB reviewed the interim analysis and based on a pre-specified algorithm recommended a final sample size of 3,000 patients, and that's what the results were. Baseline demographics, here you can see between control and SEP group, females were higher in the SEP group. They have higher risks of stroke, unfortunately. The risk was well balanced between both groups. There was no difference between the two groups regarding anesthesia, valve anatomy, prosthetic valve type, and balloon dilatation, so there were no problems with that. And here comes something that is really very important. The primary endpoint, stroke at 72 hours discharge, you can see in blue and particularly in yellow or beige, you can see there was a 21% relative risk reduction in all stroke through 72 hours, but that was not statistically significant. However, there was a reduction. And if we take the disabling stroke, the real disastrous part of stroke or of injury, then we see a 60% relative risk reduction in disabling stroke to 72 hours, and that was statistically significant. So let's not forget that even though this is a secondary endpoint, but we can argue and discuss secondary endpoints or primary endpoints. It is what it is, but from a clinical standpoint, I think that's very meaningful. And if we look at the details of disabling stroke, you can see here basically this device protects the brain from ischemic stroke, very important. And this is something that I think in the control group 20 and in the SEP group 8, and that's something that we should not forget. Also, if we look at the disabling stroke in the SEP treated patients, only 2 of the ones that are listed in the stroke part could be prevented with sentinel. Out of the ones of 1,500 patients, and you can see here those with the red arrow. All the others were either not protected or hemorrhagic, or the location was undetermined, or the device wasn't deployed. So it was really quite successful. Outcomes in patients with stroke, we know that to the right side. Discharge home with no services. Obviously, with and without stroke, there is a different there's a difference favoring those that you better don't have a stroke. Subgroup analysis, it's very interesting, all favor SAP. And if you look, something that's not been answered until today, the difference between OUS and US, if you take the lower part, we don't know why that's happening, but it is what it is, and we have to kind of further see why this discrepancy is happening. So in conclusion, then, the use of SEP was feasible in 95% of attempted patients that was safe with no major complications. Use of SEP did not reduce overall periprocedural cerebral injury. Use of SEP, however, reduced disabling strokes, and no specific subgroups were identified which strongly favored SEP use for overall stroke reduction. Limitations are summarized here. Time is running out. Every study has limitations, particularly this one, which we can discuss, but at the end of the day, it was not a perfect randomized trial, but it was a randomized trial, so we have to take it as such. A few final remarks. Probably this study will not convince the non-users to use SEP, despite reduction of disabling strokes. The users will continue to use SEP, so not much is happening here. Let us also not forget the reason for these injuries in the brain is debris that comes off at every procedure. The sources of emboli have also not changed. So there's no reason why this should go down. New brain lesions by MRI post-TAVR is brain injury and certainly not benign. And then let's not forget, the FDA panel did not approve Sentinel based on efficacy or statistics for that matter, but rather on common sense, namely removal of debris after the TAVR procedure. As you all know, the panel was large. Each individual member of that panel was asked, would you like to have TAVR with or without? The majority, except one, said, I would like to have a protected TAVR procedure. One, that was a statistician, said no. So, embolic protection devices, the first one, granted, first generation device, but we will be doing better as things move forward. The take-home message then, SEP use prevents disabling strokes, therefore the Sentinel device should be considered for all patients undergoing TAVR. Since the safety of the device was established in both randomized trials and registries, cost considerations may be an important determinant for the use of SEP after TAVR procedure. With that, I would like to come to the very last slides. When should we use SEP? Summarized here in high-risk patients, and some of them are summarized here. At least that's my opinion. In summary then, I don't need to summarize again, but I think it is important that we don't forget some things I believe cannot be answered by randomized trials. There should be common sense, much rather not having a stroke than having a stroke, regardless of what the outcome of a randomized trial is. And we can see this struggle continuing with bicuspid aortic stenosis. People say yes, people say no. Meanwhile, we continue doing it with fairly good results. With that, I would like to thank Roxana for the invitation. Christmas, a pre-Christmas meeting in New York City is always something special. And wishing you a very successful meeting today.
Thank you so much. Thank you.